YouTube page and through the CAMC Facebook page. So please follow both of those great resources. In order to keep this roundtable organized, we'll be using the raised hand feature, manually unmuting you so you can make a statement. And if you don't know where the raised hand feature is found, look on the black Zoom bar, navigation bar, and open the participants icon. On the bottom of the bar, you'll see a small hand icon. You can click that and we'll start our roundtable discussion, or we'll be able to reach back to you. We'll be calling and unmuting names in the order that the hands are raised. So with that, let's go ahead and we're going to do this in order. So we'll start out with Dr. Shah sharing with us from probably from his home office down in Lake Nona. Dr. Shah.
Hello, how's everyone doing?
They're all muted, so I hope they're
all muted, so I can't hear anything. Sorry, well, thank you, Ken. Thank you, Amy, for allowing me to participate in this. I'm happy to talk. You can see I'm actually in St. Petersburg at the moment. That isn't St. Pete, that's just the background, doing coronavirus testing. So I think for my piece, I don't have any slides. I'm really just gonna start from beginning to end and discuss SARS-CoV-2 testing and testing resources and availability and things that may impact the patient with cancer. As Ken mentioned, I'm the medical director of a laboratory located down in Lake Nona in Medical City. And we are what we would call a high complexity molecular diagnostics testing laboratory. So we do high-end genetic testing, not just for coronavirus, but for other genes and genomics that may be of interest to people with cancer. We do cancer predisposition testing like BRCA1, BRCA2, hereditary polyposis colorectal cancer, amongst many others. But I think for the purpose of this conversation, I'm really just going to talk about SARS-CoV-2 or COVID-19. So as everyone is well aware, we're in this kind of new world of coronavirus, and it's impacting our daily lives. It's impacting our ability to care for people. So this coronavirus is also called SARS-CoV-2, is a RNA virus. And that means that the heritable component or the component that transmits its own information is RNA instead of DNA. Not that that's so important, but just to let you know, it tends to be an RNA virus. So currently, the way to detect this virus is a number of different ways. We can do samples from the nasopharynx, so that's doing a nasopharyngeal swab. You can also do samples from the oropharynx, so oropharyngeal swabs. The scientific data suggests that the difference is fairly negligible. So nasopharyngeal is the gold standard sample, but oropharyngeal swabs, the sensitivity of the test only drops by a few percentage. And so in screening asymptomatic people, oropharyngeal may be just as useful as nasopharyngeal swabs. You can also use stool as a sample type. Stool tends to be positive just slightly later than nasopharyngeal or oropharyngeal, but it's actually quite useful in patients that may not have great mobility or may not tolerate a nasopharyngeal or oropharyngeal swab by any other method. So those are the three sample types for the PCR test. And I think everyone is probably aware of PCR, but PCR stands for polymerase chain reaction. This is the test that's approved by the CDC under emergency use authorization. And this is the test that is performed by almost all commercial laboratories. This is a very good test. It has, in the laboratory setting, it has almost 100% sensitivity and 100% specificity for detecting SARS-CoV-2 or the COVID-19 virus. In real world settings, the sensitivity and specificity is still above 95%. So it's quite good. So the way this test works is we're looking for specific parts of the actual nucleic acid or the RNA of the SARS-CoV-2 virus. So it's actually detecting the presence of virus or virus nucleic acids. So this is why this is the gold standard, because obviously you're not going to have the RNA if the virus doesn't exist. And this is also why the gold standard is for nasopharyngeal or oropharyngeal testing. In general, the median time to people developing symptoms of COVID-19 is about 6.5 days. Meaning, if I coughed on Ken here at the moment and I was positive, and Ken had exposure, if he turns positive, the reality is he would probably have symptoms around 6 days. But remember, it's a bell curve. So some people develop symptoms within 1 day, and some even out to 2 weeks, but on average, it's about 6 days. So what makes this virus unique and difficult, and the reason it's causing such great difficulty is during that incubation period, people are asymptomatic, right? They have no symptoms, but they can still transmit the virus. They're infectious. And this is why, we should be advocating masks and other strategies for reducing the transmission. In Florida, we're currently spiking again. But regardless, on average, the person who's infected infects between 1 to 2 other people in that asymptomatic period. In contrast, like compared to the flu has what's called a R naught of like 0.2. That means for every 10 people infected with the flu, essentially there's one additional infection. This is 10 times more infectious than the flu, okay? So this PCR test is very good for screening populations or screening asymptomatic individuals to see if they are infected with SARS-CoV-2. So we're using it in the setting of mass screening. We're using the PCR test in the setting of testing people who have known exposure or established exposure, or testing people who are at high risk and now going to undergo a procedure like chemotherapy or go to an infusion center or go someplace where there is additional risk. So that's essentially the PCR test in a nutshell. Our laboratory turns the test around in 24 hours. It varies across the country. On average, it's 3 to 5 days, but we've decided that we are only going to take the number of specimens on a daily basis that we can turn around in 24 hours. Only because people need to make clinical decisions one way or another, right? And so in our mind, it doesn't make too much sense to get a test result back 3 to 5 days later. For the cancer patient, one of the primary uses of the PCR test, in addition to what I just mentioned, is to make sure, once again, that they're clear to then enter a facility for chemotherapy, for surgery, etc. We're seeing that many physicians and many healthcare providers are now requiring essentially a COVID-19 PCR test before they're allowing access to the services. So, for example, many gastroenterologists are requiring testing before scheduling endoscopies, right? Because endoscopies are high-risk procedures where there's lots of saliva, et cetera, that can be potentially infectious. And so one of the advantages that we can have, or one of the things that we can do, is provide this SARS-CoV-2 PCR testing so people can essentially be cleared in order to get secondary services. I think for the cancer patient, this is probably the biggest limitation, is being able to access these tests and access them in a reasonable time frame to be able to do whatever they need to do. In addition to PCR testing, I'm going to talk about now antibody testing. So we do antibody testing in my laboratory. There's two different types of antibody tests. One is what's called a point of care antibody test. This is like the finger prick test that you've probably seen. You use a lancet, do a finger stick, and then you put it on a little cartridge. It looks like a little pregnancy test. And then, a little lines show up that you read. And then in my laboratory, we also do what I would call semi-quantitative antibody testing. So this actually requires a blood specimen, either in a light blue top, green top, or lavender. Light blue or green preferred, but lavender also acceptable. And that's pretty much most laboratories for the most part. The little point of care test kits are not very good. So we don't recommend them. We do them if people request them, but their positive predictive value is about 3%. So that means they're just not very good for detecting people who are actually infected or in the infectious stage. Their negative predictive value is actually quite good, like 97%. So they can be useful for knowing that people haven't been exposed. And so one strategy is to use the PCR test and then use these point of care tests periodically afterwards in order to show that people haven't been infected in that median time. But those tests just are not very good. And the reason for that is these antibody tests, as you're probably well aware, when we are infected with something, we develop antibodies to that. We develop two types of antibodies. One is called IgM, the other is called IgG. IgM antibodies start increasing about 48 hours after infection, IgG about 10 to 12 days afterwards. So in that time frame where people are asymptomatic, you're not going to develop antibodies, and so you can't use this to diagnose people. The real purpose of antibody testing is really to know that people have been exposed or recovered in the past. So the IgG antibody is quite good after 10 days of exposure. Not very good in that 0 to 10 days, but after 10 days from time of exposure, it's quite good. So we all, for example, use it in patients that have been infected to show that they have antibodies, so they may be able to go back to an assisted living facility or a nursing facility or a rehab, right? Because many times once people are infected, they have to self-quarantine or actively quarantine, and they're excluded from either going back to their residence or going to an infusion center or somewhere else. So we can use a combination of the PCR and antibody testing on the backside to really distinguish that someone is over an infection and that they have antibodies to SARS-CoV-2, which usually permits them to resume activities and services. And so that's antibody testing in a nutshell for the most part. Once again, the IgM is not very good. The IgG is quite good. I will just lastly, because I know I'm running out of time, I'm going to mention a couple more just quick tidbits of facts. So at the moment, almost all insurance is covering SARS-CoV-2 testing without asking for copays. Even high deductible plans are covering it without having to meet the deductible or having people pay their portion of that deductible. That guidance from most payers is only through June. And so this is changing on a month-to-month basis. We're already seeing some pushback from like United Healthcare in particular regarding paying. Most of the payers are pretty good in covering it. It is not at the moment requiring prior authorization, and it can be ordered by any physician, I think any advanced practice nurse. And the governor also put in guidance that pharmacists in the state of Florida can order the testing, just to let you know. On average, just to let you know, like I said, insurance is paying for the bulk of these, but the cash price or out of pay for most labs is somewhere going to be between $100 and $150 for that PCR test if you have to provide guidance to your patients. The Department of Health is offering testing, but it tends to be somewhat intermittent on a weekly basis. So that's often a good source for testing if you need, but that requires some logistics and coordination. The lastly, what I will tell you is we have also approved the test in saliva. So we can, in addition, do saliva samples instead of nasopharyngeal or oropharyngeal swabs. I still prefer the swabs because we have a requirement of about 2.5 milliliters of saliva, and that's actually quite a lot for most people to spit into a tube. The advantage there is really more so on access and shipping, right? Like you could send someone a saliva kit and then they don't really require a healthcare professional to do a swab in order to spit in a cup and get back. Just to let you know, the caveat on the saliva test is we've applied to the FDA for approval, but we have not received approval from the FDA on that. But we have internal data and there's plenty of scientific medical data out there that saliva-based testing is just as good as nasopharyngeal or oropharyngeal testing for detection of SARS-CoV-2. And I will stop there.
Well, thank you, Dr. Shah. I know that if you're in St. Petersburg, I think you're probably working down there. And
yes.
If you are, do we have you for another 45 minutes or should we ask questions now?
I will, I can be available, but actually I prefer to drive back. So if you don't mind, I'd love to take questions now.
Sure. And let me start off, and then if anybody has any questions or answers, again, use the question and answer box. I just checked that there's nothing there right now. I just came off a 2-hour disaster coalition training for 9 counties along the East Coast, and heard in Brevard they were running 20 and 30, and now they're up to 148 in almost overnight within the last few. So you mentioned spiking. Is that something that's going to it sounds like it's going to have a significant impact on us, probably not just in that county, but in other counties as well?
Yes. So we're in touch with the Department of Health. Just to give you an idea, when coronavirus started, the number of positives our small lab was getting on a daily basis was 1 to 2. On Tuesday, I had to call 60 people to tell them they were positive. So right now, we are at a much higher rate than we were even in March. So in testing asymptomatic people, like people essentially walking around, we're finding about 2 to 3% of people are positive that we're testing. And the Department of Health numbers are just slightly higher, and this is Orange County. So at the moment, that's a lot of individuals out there. So yes, this is a time for extra caution to be put in place.
And let me ask you one other question, and that is there's some concern about the use of the term second wave. They were talking about that for later this year, but it seems like we really haven't had and it's funny that you should have a view of ocean waves behind you. I don't think we've had a wave move out yet. Have you heard about the use of that term second wave and any thoughts on that?
Yeah, so the reality is we are not really in a second wave. This is just a continuation of the first wave, right? So what happened is our first wave went up. We did actually a good job of flattening the curve by social distancing, self-quarantining, et cetera. So the curve started to go down just a little bit. So it dropped about 5%, and then it's been like steady state, solid across the board. And now it's starting to climb back up. So we are still, I think, on a continuation of the first curve. We've never consistently had that curve go down. And by consistently, the guidelines set forth by the epidemiologist was at least 14 days of the trend going down. And we've never had more than 2 or 3 days of a trend going down. We had like a 3-day trend, and then it's been flat constantly. So yes, this is a time of real concern in Florida.
Well, Doctor, thank you. And thank you for staying with us as long as you can. We're going to switch over to Amy Roberts now. Amy's been doing quite a job in helping focus on the stress as it relates to cancer patients. So Amy, go ahead and share with us what you're doing and some of the activities.
Sure. Let me just share my screen real quickly here, if I can. All right. So I wanted to thank you again, Dr. Shah, for coming and speaking with us. We really appreciate that. I am an oncology social worker. So basically, the work that I do is to help alleviate the conditions of those in need. And I'm doing that by addressing a lot of the psychosocial factors of COVID and cancer, which is basically the social factors that affect individuals on a very personal way, affects their thoughts, their behaviors, their mental health. So I thought it would be appropriate to start, the talk with some personal stories from some of the patients here in the community and the types of things that they're facing. So I'm just going to briefly share a few of those. I talked with a wife who had to say goodbye to her husband. He was in his mid-50s, I guess, when he contracted the virus and had some underlying health issues. She had to say goodbye to him through FaceTime on her phone with her 20 or 19-year-old daughter sitting at his bedside, because she was not allowed to go into the ICU. I sat with a mom in our clinic who was in tears because she had just received a call that her daughter needed emergency surgery at the hospital, and she couldn't come and sit with her daughter during that time or be with her daughter while her daughter was hospitalized. She had to wait till her daughter was released to come home. And, the mom is, of course, dealing with cancer at this point as well. I've talked with cancer patients, many of whom are taking care of a spouse that has dementia. And so, staying inside a contained area for long periods of time with this disruption of routine of their one outing a day that they do or their little habits that they do can really create a lot of stress for both him with dementia and her with cancer. You can imagine him asking, when are we going to go do this? When are we going to go do that? And not really being able to understand all the dynamics of what's happening. I've talked with some cancer patients who, have shared with me, I'm on immune therapy drugs, but I'm doing okay. I wanted to go to the grocery store, so I got my little mask and I've got my hand sanitizer, and I'm looking at how many cars are in the parking lot, and I'm thinking, this feels okay. I think this is okay. Is this an activity that's risky, or is this an activity that's acceptable? And the thing that she said that really got me was, if I make a mistake, this is a huge mistake. This is a life or death mistake. It's not just something small. So you can imagine the level of anxiety just on the day-to-day happenings, not to mention the heartbreaking stories that people have lovingly trusted me with during this time. The other issues is that this isolation and this illness really affects our ability to cope, our healthy coping skills. So, my cancer patients, a lot of them have go to their water aerobics. It's low impact. They can get their exercise. They get outside. They socialize. They laugh. They listen to music. And those good, healthy coping skills are now taken away. Going for walks in the neighborhood. It's 100 degrees now and raining every day. Postpone medical procedures. So I've had people tell me they had to postpone dental work, hip surgeries, knee surgeries. So they're dealing with chronic pain that's affecting daily life every single day. And not to mention the ability to get cancer screenings, which can very, very strongly impact somebody's ability to survive their cancer or not, depending on what stage it's found at. So I know those stories, I breezed through them in seconds, but I know that everybody on this call probably can relate to that, probably has very similar experiences and understands the gravity of how all of this affects us mentally, emotionally, socially. I'm going to just breeze through the statistics real quickly, but during the census, 42,000 participants responded in 1 week from May 5th to May 12th. And they found that 1/3 of Americans are now showing signs of clinical anxiety, depression. These are just some slides from that. The top one being most combined anxiety and depression, then just anxiety, then just depression. Oddly enough, to me, the younger people are the ones with the highest levels of depression, between ages 18 and 29, and it goes down as they age. Same thing with both anxiety and depression. And lastly, which isn't that surprising, but people with the higher income worry way less. So the highest income, maybe 40% of that population is worried, where those with the lowest income, it's closer to 70% of the population. So in thinking about why that would be, it's also important to consider that this coronavirus, its impact really affects everybody very differently, depending on some social factors. Our poor obviously are having cancer at higher rates, but also facing difficulty from the shutdown. The working poor are less likely to be able to work from home on laptops and computers. Their children that are in school are less likely to have access to online learning for their schooling. So their choice is to be either unemployed or to work, but then be considered an essential worker and face possible risk for coronavirus. In Marion County, our unemployment is about 12.6 right now, which is a little lower than the state average. But another challenge or barrier is that I've had many people tell me they're unable to access the unemployment in this state. So when you think about lower income, loss of jobs, loss of health insurance, obviously those people are going to likely be more at risk for coronavirus, but also have greater obstacles in accessing healthcare. Just this week alone, I've had 2 individuals who had lost insurance, knew something was wrong, postponed getting healthcare, and are now navigating a health system with no health insurance and very advanced disease that, had it been found early, maybe could have been more treatable, but now their survival rates are decreased. And we're navigating, how do we access Social Security when the office is closed, Medicaid while the office is closed. So there's a lot of barriers that way as well. Just to speak very briefly, and I'm trying to stick to our time frame, but race can also play a factor. 30% of our nursing population are African American, and 53% of our agriculture workers are Hispanic. So, that just highlights kind of why we may see different ethnicities being affected differently. And there's some statistics there if you wanted to look at that. Recently, Alachua County, which is a sister county to us, tested, I think, 100 agricultural watermelon workers, and 92 of them tested positive for the coronavirus. One of our partners from Rural Women's Health Project shared with me her words. I want to share them to do her honest, but she says, there's a sudden desire to test farm workers and Latinos. There are complaints that Latinos are not compliant during contact tracing without understanding what is at risk in terms of employment, housing, immigration, and general safety. So suddenly this community is of interest, but historically there has been disinterest in the public health system. So the target communities suffer, and then we blame the communities instead of our public health system. So she's saying, they've been advocating for masks and help and things written in Spanish, for a long time and not gotten a lot of attention, but now all of a sudden people are ready to test these populations. So there's a little mistrust there, and that's a big challenge as well. So again, I know I shared really heavy stories and statistics of what we're seeing. As a mental health counselor, I think we will see an increase in depression, anxiety, suicide, and probably a lot of post-traumatic stress with our frontline workers. I say these things, we all know these things, it's good to give light to them, but also to say, you know, that we are gathered here today because we are a network of people that want to help others. My patients that had advanced disease and no funding, I was able to talk with somebody at the hospital that really fought to get them a procedure, somebody at the transport company that was able to bend the rules to make sure they could get to a surgical appointment that they needed, a local charity that was able to donate help for rent. And so Jennifer Martinez will be our next speaker. She's going to address how our community is all pulling together, how we're serving these people, how we're overcoming these disparities and these barriers. But so will the discussion piece at the end of this presentation, because I know we have great advocates here with hospice, with Rural Women's Health Project, with Marion Senior Services, Interfaith, all these agencies that are here to sort of collectively serve these at-risk populations and hopefully connect them to the mental health resources and services that they need. So reach out to your oncology social workers and your clinics, your mental health, because a lot of us are mental health counselors, licensed counselors, and community. And that's all, I think that's all I have time for, but thank you guys for having me on. I really appreciate it. Oh, and then, sorry, the final slide is what can we do as individuals to manage this heaviness and this emotional toll. There's a lot of handouts on information on this. If you go to rboi.com, I actually have a whole webinar on secondary trauma and managing some of the emotional tolls dealing with this as well. So thank you guys.
Thank you, Amy, as usual. And I was going to here briefly to ask you to fill us in on what you've been doing online on, I believe, a weekly basis. But let's come back to that when we get to the question period. We'll go ahead and see what's happening. You've been talking about specific segments of the population, and certainly the seniors segment is a huge population as well. So with that, we'll turn it over to Jennifer Martinez to talk about Marion Senior Services.
Good afternoon, everybody. Thank you again for allowing me to join you all. I was honored when Amy asked me. So if you give me just a second, I'm going to try and share my screen. Let's see if I can do this like we rehearsed. Give me just one moment. Okay, can everybody see the slides? Okay. So my name is Jennifer Martinez. I'm the Executive Director of Marion Senior Services, and I don't want our name to think that we only serve seniors. We serve entire families, so all ages. And we are here to maintain the independence of our seniors and also their families as caregivers. Marion County is very vast, and we have probably over a third of our population that are 60 and over. So it's very important for us to collaborate with our partners. Our mission statement is supporting the elderly, disabled, and disadvantaged residents of Marion County and their families with dignity, respect, and compassion to maintain independence. Our vision statement is working collaboratively with our partners to help provide a safe, nurturing environment that empowers all that we serve toward well-lived lives and maintaining independence. This is so extremely important because there is an art of aging and to aging. So we're really trying to work with our partners to offer resources within our community to help those individuals maintain independence. I know I keep repeating myself. It's so important to maintain independence. So most importantly, I found it funny that Amy's last little point on her last slide was know your resources, and then my name had an exclamation point behind it. It's so important to know your resources and what's available to you and to those you love. more importantly, I want to encourage you to reach out to those resources and ask for that help. So like I said, our mission statement is assisting the elderly, disadvantaged, and disabled residents of Marion County to maintain their independent living status. We were founded over 40 years ago. It was actually a group of women seeing a need within their neighborhood and among their neighbors to receive food. And from that, we've grown to an over $7 million agency. We are the Department of Elder Affairs lead agency and also the Community Transportation Coordinator for Marion County. I'd like to start with Meals on Wheels and our nutrition component. Like I said, we began with 13 meals to neighbors. Now we serve more than 400 meals daily. And this is actually an outdated slide, and I didn't realize it until after I sent it. But since COVID, we've expanded our nutrition programs. It was very important as the most vulnerable population when it comes to COVID to maintaining the safety and security of our clients. Not only that, when you think about our agency, the majority of our staff are senior citizens with underlying health issues. So not only did we have to protect those we serve, we also had to protect those that we're serving. We have expanded, like I said, the program to include a restaurant program that we have named Warm Meals, Warm Hearts. Our actual current food purveyor was getting inundated, obviously, from so many of our other partnering agencies and the need for food, that the department opened up the use of using restaurants as emergency purveyors. So we have actually partnered with local restaurants, not only to support our seniors in making sure that they're being fed, but also to support our local economy. So it was like a win-win-win for everyone, and I could not be more happy that they allowed us to do that. But specifically to Meals on Wheels, our goal is to provide a hot lunchtime meal that meets nutritional requirements Monday through Friday. It's also a daily well-being check. Whenever somebody comes on to our services, they are not just a client, they actually become family. Our drivers know their daily routine, they know what their walking gait is, they know what their speech is like. So if something's off, we have the ability to contact a family member, a friend, a neighbor. We have great ties with our local first responders and law enforcement. So if we can't get a hold of them personally, then we reach out to those partners and they help us make that happen. When it comes to cancer patients, we really have a lot of services available, including Meals on Wheels. Caregivers 60 and over also are eligible for this program. So again, one of the biggest things is, speaking personally, my mother had cancer and also my mother-in-law had cancer. My mom survived and is a survivor. My mother-in-law did not. So when it came to their nutrition, I saw a difference between the two, and it just made me realize how important nutrition is. So know that this is a resource to you if you are 60 and over, that Meals on Wheels is available. And like I said, it's more than just a meal. We also, in a normal environment, we would have congregate dining sites throughout Marion County. Unfortunately, we do not have those right now, but we are serving those folks through Warm Meals, Warm Hearts. It's important for us to maintain that connection, that human connection that we all have to have. And I think going back to talking about what Amy was talking about, depression, isolation is not something new to us. It's something that we battle every day. So we are having to become more creative in how we reach out to these folks and touch them. So fighting hunger, isolation, and loss of independence, we're still in full swing. I'm looking out my window right now and we have a program happening, and everybody's so happy to see each other. The next component that we have is in-home support. This is another resource for our caregivers and our cancer patients. Adult daycare is something that we offer in order to give respite to the caregivers, caregiver support. If you do not take care of yourself as a caregiver, how in the world are we supposed to expect you to take care of your loved one? So maintaining personal independence in order to remain a caregiver is hugely important. We also offer case management to our clients. We have an emergency alert response program to where we have the ability to hook you up with the buttons. We have homemaker assistance. You know, we always find people that take this for granted. Keeping your home nice and neat and healthy is hugely important. So making sure those dishes don't pile up in the sink, making sure that you have your floor swept and maintained so you don't have a fall risk is very important. Personal care, brushing your teeth, taking a shower, again, how you feel about yourself and maintaining personal hygiene affects your overall well-being. So personal care is hugely important. Respite care, again, going out to the caregivers. We are also the arm for adult protective services with DCF. So if something comes in when it comes to elder abuse, depending on what their needs might be, they will come to us. So crisis management, what we found with adult protective services and what we've been trying to really change the conversation of is becoming more proactive in your own personal health care plan so you don't fall into crisis. One of the biggest things and excuses that we hear is they don't want to burden their friends and their family. I understand that, and you don't want to ask for help. However, if you don't ask for help when you truly need it, not becoming a burden, ultimately you become the burden by not asking for help. Financial hardships, distress, longer recovery, if any, you know, we all know that if a fall takes place, it deteriorates your personal outcomes by a lot. So we want to make sure that you do not fall and you have the ability to recover in a positive way. Rehabilitation facilities, we work with them quite closely. Self-neglect, again, asking for help is not a sign of weakness, it's a sign of strength. So I hope that you all ask for help. Depression, isolation, things that we're all facing now with COVID and everything else going on in our world. Depression is highly visible, and we do not want you to go down the road of depression. And also isolation, again, making sure we're connecting with those. Something else that we've been able to do through COVID and some of our financial resources, we've been doing telephone reassurance. So we're not personally going in and physically seeing all of our clients because we want to maintain their safety. So we're calling them on a daily basis and making sure that they are okay. And if there's anything that we can do to help them. We also are offering shopping assistance to our clients so they don't have to go to the stores and we can go on their behalf. So please keep that in mind as well. And frail and dependent on those around them. Marion Transit is the special kid in the building because they offer services to folks that aren't necessarily seniors. They serve all ages. We transport infants all the way to however old. So don't think that you have to be a senior in order to use Marion Transit. The majority of our clients that we have served and remain serving are dialysis. When we were facing COVID, our leadership got together and we decided, because so many of us know that our clients will lose their independence if we don't help them. So it was very important that we kept the buses going, the meals running, and having the in-home support that they need in order to maintain their independence. So to qualify for Marion Transit, you have to be transportation disadvantaged, you have to be disabled, or you can be a senior citizen. Transportation disadvantaged means something, just a quick example. If you had a colonoscopy and you didn't have anybody to drive you and you had to be put under, you could qualify for Marion Transit. You also, as a caregiver, can ride along with your family member. It is door to door. So we will come to the door and pick you up and take you to your appointment. Our drivers arrive at the office about 5 o'clock in the morning, and they're here probably about until 7 o'clock at night or whenever the last trip ends. We do ask, because we transport close to 300 folks currently. Typically on a normal day, we do anywhere from 400 to 450 trips. So it's important that we get the reservations as quickly as possible so we can make sure that we can social distance on the buses and make sure that we have the proper schedule for everyone. The number is different for Marion Transit when you call for services than our main line. So please take a note of that. It's 620-3071. That goes directly to Marion Transit, and they can help you with eligibility questions and getting you established in our system. Volunteering, we offer a lot of volunteer opportunities. And I say this, I'm gonna list all of the opportunities that we host personally, but any way that you can maintain your purpose, anything that you have your heart set on, I encourage you to being active. Going back to my personal experience between my mom and my mother-in-law. My mom remained active. She kept teaching. She would take naps in her classroom in the closet. My mother-in-law didn't remain as active and had a different outcome. So when you look at cancer patients and the difference between the two, remaining active and volunteering and having that purpose and drive is hugely important. Specifically for our agency, we have senior companions. Meals on Wheels, we would not be able to operate without our volunteers. We have 17 different routes. Actually, we have 19 now because of all the clients that we have added on. The majority of those routes are volunteer driven. Our volunteers and our drivers are not going into the homes currently. They're door to door. Caregiver relief, allowing our caregivers to get a break and give themselves time to themselves. Telephone reassurance, calling and just checking on those folks. Friendly visitors, currently not being administered, neither is the homemaking, but those folks are being encouraged to help participate in telephone reassurance in our food commodity program. That's what's happening currently right now as I speak. And then we also have a youth association for Marion seniors. We call them our YAMs. Something that our board identified and has really worked towards rekindling the respect that our youth, I don't want to say have lost, because as I look out my window, all I see is youth right now, but really re-engaging our youth with our seniors again. The commodities program.
Jennifer.
Sorry. Go ahead.
I'm sorry to interrupt. We've got one more presenter, and
sure.
So if we can just wrap up, it's just your last slide, or?
Yep, I can go funding through really quick. Our funding, we have a slew of funding. The majority of it is through the Department of Elder Affairs, the state of Florida, the Department of Transportation, United Way. We've been a funded partner for almost 50 years. County Commission, client contributions, and community support. And don't resent growing old. Too many are denied the privilege. Like I said, I lost my mother-in-law at 56 from cancer, and every day I think that there is a way to live in the art of aging. So thank you for your time.
Well, I thank you very much. And I think the important thing here is that what you've shared is significant, obviously, for Marion County, but also most of those services I know from serving as the board chair for our local area agency on aging is something that, as we look across our 7 service counties, is available in other counties as well. Yeah. So I think this has been a real eye-opener for folks, and I appreciate your time. We did add today another speaker, and again, Doctor, I'm afraid I've not heard your name before, Gopalan, who's an oncologist who's joined us, and I'll go ahead and ask her to present here.
Great, thank you. So it's Dr. Gopalan, so it's pretty close. I don't know if we can see it. Are you seeing my screen at all? Or my slides?
Yes, your slides are showing. Mm-hmm.
Great. So I'm going to just go through these fast because we don't have much time. Everyone knows, or I'm sure everyone assumes, that the cancer patients are very at high risk for infection. The treatments and the cancer itself makes them at high risk due to their effect on the immune system. You know, the COVID, we don't have a lot of cancer studies on cancer patients. We have some preliminary stuff. There was a study in China, which only had actually 18 cancer patients. But they showed that even with these 18 cancer patients, they seemed like they were definitely at a higher risk than the non-cancer patients who had COVID-19 to develop severe events, meaning hospitalization, intubation, and death. And even then, their time to develop these was much more rapid than the non-cancer patient. And this is just a couple more slides looking at these systematic reviews, meta-analysis, these pooled studies of lots of patients. And they pulled out the patients who had cancer, and they showed that the mortality rate was higher in patients who had cancer versus not, and as well as the ICU admission rate. Here's another study, again, showing that there's a higher mortality. So a couple of the really interesting things that the cancer community is doing is they're trying to get a better understanding of how cancer patients are being impacted by COVID-19. So they actually have this study going on that the National Cancer Institute has, and it's just, they're enrolling 2,000 patients, collecting blood samples, medical information, medical images. If the patient is agreeable, the physician will help assist in enrolling them into this database. And they're going to follow them for 2 years and see how they do. How does having had COVID affect their cancer outcome? How does it affect their treatment? And then other things will be looking for genetic risk factors and markers that maybe predict who's going to be at higher risk for getting serious illness. And then again, just getting this pool of information for future research. One other really interesting thing they have is this cancer, COVID-19 and Cancer Consortium. This is an actual registry. They've just hot off the press, they have results that were presented earlier this month at our virtual ASCO, our national meeting. And they saw that about 43% of the patients who had cancer and COVID-19 were on active treatment. So that's pretty significant. And you can see that there's a 10% mortality rate. If you look at the general population, it's about 5%, 5.5%. So we have definitely at least about a double percent chance of mortality, risk of mortality, if you do have COVID-19. So I'm just going to skip this. So one of the interesting things is, when it hit us, we didn't know what to do. I mean, all of our patients, as I said, are on immunosuppressed. What do we do? Do we stop everyone's treatment? Do we keep it going? So there, ASCO and also ASH and a lot of other organizations have provided resources for us. So I just looked at ASCO because I'm an oncologist, so very ASCO centric, but they have some resources to help guide us on what to do, who should we see. They've provided kind of prioritized patients based on how life-threatening their cancer is. And, patients, for example, with leukemia and lymphoma, we can't really say, well, sorry, you're in the pandemic. We'll just have to wait a few months. A few months from now, they won't be around. So those patients, you just have to bite the bullet and treat them. Yes, they're going to be immunosuppressed severely, but otherwise otherwise they will pass away from their cancer before you have a chance to cure them. So using this stratification, they've developed some suggestions to minimize risks for patients. So if at all possible, like patients who are just getting routine follow-up labs or scans, we're using a lot more telemedicine. And I think this is not just in oncology, but a lot of other specialties as well. We're delaying treatments if, for example, patients are getting maintenance therapy, so their main treatment's done, and we're just in the maintenance phase trying to suppress future recurrences. If patients are getting oral agents, we're doing a lot of telemedicine and then just mailing the drug to them rather than making them come in and see us face-to-face and pick up their drugs from pharmacy. Even in infusion centers, our infusion center here, we're social distancing. We're only putting patients in every other chair. So we're definitely trying to help minimize the risk for the patients, understanding there's no, nothing they have to be treated, they have to be treated. I just kind of threw this in, and someone else alluded to this, that one of the problems we're seeing is that we're definitely seeing delayed diagnoses. Our cancer screening studies have been put on hold. Even in patients with a high suspicion of cancer, the workup, like the biopsies, the scans are being put on hold. So that's something that in the future may impact us. We may see a higher trend of patients who are in higher stages of cancer coming to see us. So that was just, I blew through the slides just to kind of show just a little snippet of what we're facing when we're actually looking at patients and trying to cope with how to approach this world, both the patients who don't have it and also the patients who do have it. Okay.
Doctor, thank you. It's a shame you had to speed through, and we do have a break here coming up shortly focused on Marion County. But thank you so much for joining us today. And I noticed the MD PhD, we started out with an MD PhD and ended with one. And I believe there's some connection there as well.
Yes, just a little. It's Dr. Shah's my husband.
Dr. Shah, is that my understanding?
That's right.
So we bookended the program today, but thank you so much. And that was certainly an excellent look at something that's very scary for patients, obviously cancer patients at this time. And your information was very helpful, I'm sure, from the standpoint of helping. And as Amy shared with us, the issue with stress and do I get taken care of now or not? So it's nice to see that there's something there in terms of based on acuity of and the stage of the cancer. There was one question that came in. Let me back up for Jennifer. And that one related to, does MT pick up homeless if they give an address? And this was asking specifically for colonoscopy.
Yes.
Jennifer can.
We would absolutely do that. We work with a lot of the mental health facilities to try and get the resources out to the homeless, but absolutely we would be more than willing to work with and coordinate that trip. They just would need to call the Marion Transit line at 620-3071 and they can help them get that established and scheduled.
Thank you. Any other questions? If somebody would like to raise their hand, I can't see anything more than 3 people at a time. So I don't know whether I didn't see anything else in questions and answers or in chat. And we're actually coming up exactly at 1 o'clock. So I will ask for those who put slides into this today. We did record as we said we would. Are the slides that you have presented available for us to distribute? Because we did squeeze some things in and had to speed up. I see the doctor shaking her head, so that's great, Amy, and here's Jennifer. Terrific. Well, thank you all as panelists today for great information. We have a challenge to share in today's mission to spread awareness and hope in our own communities, anywhere in the 7 counties that we cover in our Cancer Alliance, but also we may have had other of the regional cancer alliances tuned in today. So appreciate your information and all the preparation that you all did. And with this, I'm not sure who I hand it off to for continuation because we wanted to also, since we're combining with CAMC, give the next 30 minutes to them. And if anybody would like to hang on and see how a very, very cohesive and well-designed Cancer Alliance is working, you are most welcome to stay for the next 30 minutes as well. Amy, is this come over to you or?
Yeah, I can speak, real briefly, and then we'll figure it out. But yeah, if you'd like to stay on for the next 30 minutes till 1:30, the hope is that everybody on the call, you know, here obviously represents agencies that are dealing with cancer and COVID. I think we have hospice on the call. We haven't really addressed what happens at end of life when dealing with COVID too much. We have Marion Transit, Marion Senior Services, and some other really fabulous agencies. So I would encourage anybody that wants to stay on the call to share what your programs are doing, how we can help each other so we don't feel so overwhelmed and on our own when reaching out to these cancer patients as a community. So I encourage whoever would like to stay on the call, we'll kind of open the chat box to anybody. If you want to, you know, raise your hand with the raise your hand feature at the bottom of the screen, we can do that. And just give everybody on the call a chance to say a few things. Thank you so much, Ken, and everybody for being here today.
Amy, I am going to have to step away. So
Okay.
I, again, want to say thank you. Like my information was on the slide. I'm more than happy to work with our partners and work with our community to ensure everybody's well-being and independence. So thank you very much for inviting me.
Thank you.
Thank you.
All right. So does anybody have any questions for us that are still on, or would anybody like to say anything about their programs here locally?
Amy, I did see a hand raised, but the name disappeared before I could see who it was.
Jessica, yes. Oh, hang on. Let me find her. Okay, Jessica, we've got you. Can you speak? Jessica?
Testing, can you hear me?
Yes, we got
Okay.
you.
Okay.
Welcome.
Well, no, I've been here and thanks so much. I don't know if I can get the video to work as well, but yes, there is a lot of helplessness and frustration and anxiety, as Amy, you pointed out the stories with your clients, of course, are throughout the community, and we've expressed them as well. On our website, our social workers battling that feeling of what in the world can we do and how can we make a difference, they banded together and came up with 100 healthy coping mechanisms for how to handle stress, and that's on our website. I had a little trouble finding it, so just bear with me, but if you go to the hospiceofmarioncounty.org, there's a blue banner at the top that says latest COVID information, and that has a lot of COVID information, but if you scroll through it, you'll see the 100 COVID coping strategies. So that's been interesting these past 2 to 3 months to have that at our fingertips to give to people. They all know this, but to remember it during a crisis, I think is key. There's really nothing new under the sun, but just to remember the resources. That word has been given to us a lot today by you and Jenny. So, so that's one idea, which is trying to peel back the onion and meet anxiety, meet frustration, meet helplessness, bear witness to that. Does that make sense?
Amy, you're muted.
Sorry about that. I was going to try to share your 100 resources. Here we go. Let me see if I can share my screen. So can you all see that? Those are her 100 COVID-19 coping strategies. And this is direct from the website of hospiceofmarioncounty.com. So thank you, Jessica, for that. And really for all the work your social workers, your nurses are doing with people that are struggling as far as trying to be with loved ones and navigate this health system that is so even more complex with the barriers put in place from COVID. We really appreciate it. Does anybody else want to put a hand up or put a comment in the panelist, the chat box for us to share with each other? Any other agencies or things you guys are doing?
Hey, Amy, it's Jennifer McCaffin. Can you hear me?
Yes.
Hi. If it's okay, I can go next.
Yes.
Okay. With the American Cancer Society, and due to the public safety concerns related to COVID, we are not setting up or coordinating patient rides to cancer-related appointments right now. We are looking on ways to have it be safe for our patients, our volunteers, the caregivers, and the staff to be able to coordinate that. So as soon as we are up and running, we will be able to let everyone know that those services are available. We do know lodging and transportation are the #1 resources that patients need from the American Cancer Society. However, we continue to assist patients through their cancer journey, even during these challenging times, with our 24/7 cancer helpline, where our trained cancer information specialists are available. They're available at midnight, 2 in the morning. They'll be available on 4th of July, on Father's Day, to provide accurate, up-to-date information and to help find valuable services and resources. They can contact us by our 800 number. It's 800-227-2345. We also have a live chat feature, or they can schedule a video chat. We have a Reach to Recovery program, and this service connects breast cancer patients with trained volunteers, and they receive peer-to-peer support. We also have a Cancer Survivors Network, and it's a way where cancer survivors can join a safe online connection to find others with similar experiences, interests, and discussion boards and chat rooms, and build their own support network. We have a personal health manager. This tool helps the patients track and organize information about a cancer diagnosis and treatment. And then we also have Tender Loving Care. It's a TLC. It helps women with appearance-related side effects find affordable wigs, hats, scarves, as well as a full range of mastectomy products. For more information, you can visit cancer.org, where you can live chat or call our 800 number 24 hours a day, 7 days a week. Thank you.
Thank you, Jennifer. These are really great resources for everybody. Is there anybody else that has something they'd like to share that their agency is has a need of, maybe a barrier or a challenge, or something that their agency is doing they feel like needs to be shared? Or even if you're a cancer patient, cancer survivor, and you would like to share something about today's presentation, you're more than welcome to speak. You just put your little hand up or put a comment in the comment box under chat.
Amy, while we give them time to do that, I was going to ask you and I mentioned it during the program and then follow up, and that is asking you to give out the information. Maybe you can put it in the chat in terms of the, I believe it's a Facebook interaction that you're doing. If you could explain that and give the connection.
Sure. So I briefly alluded to a presentation during my talk. It is on secondary trauma or post-trauma for helping professionals, healthcare, caregivers, workers, those kind of things. They're on the website rboi.com, and I'll put that in the chat box. In addition, we are running an online weekly breast cancer Zoom group, which has been so much fun. People are showing us their beautiful artwork they're doing during these COVID times. They're sharing their stories and laughing and connecting, which has been beautiful. Next week, we start a 5-week living mindfully during this pandemic and during cancer course. So that will be once a week for 5 weeks. We have about 20 people registered for that, so that's exciting. But I think what Ken is referring to specifically is I also run meditations. So Fridays at 10, any cancer patients and caregivers are welcome to meditate with me for 20 minutes. But also in the evenings at 8 during the pandemic, I've been leading live meditations on my just normal Facebook page as well for anybody that just needed that downtime. So that has been an interesting adventure and really nice to do. And those sessions are also available on rboi.com. So there's been a nice bit of technological learning for me, but also availability to take one thing and then really, spread it more throughout the community. So thank you, Ken, for bringing that up, and I'll put the RBOI.com site on here for everybody. I see we have another message. Let me see. I'm reading it right now here. Am I supposed to be reading these, Jennifer? Or
Amy, I can read it to you. It says,
okay.
Sherry Roberts, as we see an increase in COVID cases, does it appear we are relaxing too soon and should consider only scheduling priorities rather than screenings?
I appreciate the question. I feel like that could maybe be something answered better by a physician that we might have on the call. I do have pulled up a snapshot of our specific community. I can share with you guys, a screen share, because that is indeed the case. Our cases have been steadily increasing ever since the opening. We have received a grade of F as far as advancing to the next stage for our community, according to this website. So I'll be happy to share the website in the chat box. You can actually, for anybody in Florida, you can put in your specific county and look up how your county is doing, what's happening with the numbers, what's your unemployment rate, those kinds of things. But I think, the takeaway is if we're going to work and be in the community, we have to access healthcare, we have to have an economy, is to wear our masks and take precautions and do temperature checks and follow the guidelines. And that's really the only thing I know for sure, and that's from all of the literature I've read.
Amy, the other thing that we might want to do, again, that was the reason for my asking the question at the end of the 1 hour session, was to see if we could share the slides. And if you remember that last few slides were I believe it was ASCO's recommendation in terms of what needs to be addressed immediately from a cancer, and then what may be able to be delayed. So I think that goes right to the heart of that question, and those slides will be able to make available. And I'll just plan on distributing them. I'm sure CAMC can also distribute them.
Yes, perfect. And you can always ask your oncology doctor if you're already a cancer patient as well. Is this something we can do through telehealth? We've done tons of telehealth recently, or is this something I need to do right away, or can I postpone it? So seeking out advice from your medical team as well.
There was a webinar put on within the last month by Dr. Cagle at University of Florida that addressed that specific thing, and then echoed what we heard today about the use of more orals if possible. And then we heard about those being able to be sent to patients, but there clearly was an indication that they too were looking at what cancer treatment could wait, what cancer treatment can't be delayed, and acting accordingly. So the oncology community, the cancer community, is certainly looking at this and making decisions based on the science of what can wait and what can't.
It's a good question. I think professionals are trying to figure that out too. Yeah. Any other comments, questions, agencies that want to share, anything else? Oh yes, Jordy and Blake. Go ahead. Miss Blake, you can go ahead. All right, well, I have you unmuted, so feel free to jump in if you get the volume to work. Is there anybody? Oh, yeah, she says her sound may not be working. Did you want to type a comment or? And Jessica, I'll go ahead and.
I just had one more comment.
Yes.
Jessica McCune at Hospice. All of this deals to grief and what we've lost and what we're trying to learn how to endure. And thank you for all the great information about COVID-19 and how to better handle these lifting of restrictions. But we constantly educate the public about accepting and embracing and bearing witness to loss and grief. And that's part of our trip to wholeness. So one last comment about that. Thank you.
Thank you, Jess. Okay. Well, Jordan, I apologize. I don't think the volume is going to work for you, but I appreciate you being on the call and being here with us today, and everybody else that's been on the call. You know, it does take a whole community to manage this. I know it has been very disheartening, and it is a huge grief process and a new normal that everybody is trying to figure out with how do we, you know, how do we tiptoe out into the world? How do we do it safely? How do we carry compassion and kindness for everybody, and what's out there, and how do we support each other as agencies and colleagues and coworkers and cancer patients and families? So thank you everybody for being here today, for your time, and I hope you visit our websites. The Cancer Alliance has a Facebook page and a YouTube page. We will be posting this. And I think that's it for today. Unless
Thanks, Amy. Thanks, RBOI.
Okay. Thank you, guys.
Thank you, Amy. Just a closing comment. Jordan, in the comments, she writes, let's see, there will be a meeting, I guess, Wednesday, June 24th from noon to 1 with the North Central Florida Cancer Control Collaborative on the North Central Florida Cancer Report. That was the information I think she was trying to get in.
Perfect. Thank you, Jordan.
Have a wonderful day. Thank you all.
All right. Thank you, everybody.